हेलो, हेलो।
Namaskar and good morning to respected dignitaries, my colleagues and students and guests from other universities and colleges here. Today, on behalf of the organizing committee, it's my privilege to welcome you all to this special occasion of National Technology Day. Today, we come together to celebrate and the remarkable achievements of the Indian scientists, engineers, innovators, and technologists whose dedication continues to strengthen our nation, and improve our lives. This day commemorates the anniversary of successful Pokhran 2 nuclear test, which has been conducted on May 11th, 1998, which established India as a nuclear armed nation and also highlighting the country's scientific capabilities and technologies. National Technology Day reminds us that this technology is not merely machines or it's the inventions. It is about transforming all the solutions as well as the transforming its ideas and solutions, transforming them into solutions and improve this society. Keeping this spirit alive, Dr. Rangarajan has instituted the Translational Lecture Series, which has been continuing for the past few years, to bridge innovation, research, and to bring societal impact also. Today, we are honored to have amongst us the eminent speaker, Professor Dr. Ajay Singh, Vice Chancellor, Uttar Pradesh University of Medical Sciences, Saifai, whose remarkable contribution in the field of orthopedics, specifically pediatric orthopedics, has transformed countless lives. And through this, through his research, he has changed the lives of many children who brought smiles on his face by who have been suffering from congenital deformities. So we are truly privileged to have you, sir, as a distinguished academician and clinician. I now request Professor Ajay Singh to kindly take a seat on the dais, please. I also request Dr. Rangarajan, Director, CSIR-CDRI, and Dr. Vivek Bosle, Chairperson, Research and Lecture Series, to graciously accompany him to the stage, please. May I now request Dr. Rangarajan to warmly welcome Professor Ajay Singh with a bouquet of flowers as a token of respect and appreciation from CSIR-CDRI. May I now request Dr. Rangarajan to kindly deliver the opening remarks for today's talk.
Thank you, Kumar. Good morning to all of you here. It's a wonderful day to be having Professor Dr. Ajay Singh address this gathering. As you all know, it is National Technology Day, as Kumar explained, and we are combining this with the translational uh, research lecture series. And we're very, very happy that Professor Dr. Ajay Singh, Vice Chancellor, Uttar Pradesh University of Medical Sciences, Saifai, is with us today. As you heard, he's an eminent orthopedic surgeon and he has a vast experience um, in dealing with tough medical issues, particularly in the realm of orthopedics. As you know, one of the reasons for hosting this lecture series, in which we bring a clinician researcher to campus, is basically to understand and to validate the research questions that we work on. It is important that we stay aligned with the unmet medical need. It is important that we understand what emerging needs are. And it is important then to tailor our work in line with these unmet needs. And that is one of the reasons why we're so happy that Professor Ajay Singh accepted the invitation. Thank you so much. He's also been a collaborator, a long-time collaborator of some of you, Dr. Atul Goel, Dr. Ritu Trivedi. I think he's definitely no stranger to Lucknow. He's definitely no stranger to CDRI. In fact, Dr. Professor Ajay Singh has spent much of his time at KGMU, both as a student and on the faculty. So this promises to be a really interesting and insightful lecture, and I hope that all of you gain from it. National Technology Day is another way of commemorating and acknowledging the contribution of scientists and technologists in this country as an R&D organization, and one in which our one and only focus is doing scientific research and converting some percentage of that research into products. Uh, this is a special day. It's a special acknowledgement of the work we do. It's a validation of who we are, and so it's a joyous celebration in that sense. It also reminds us of work that needs to be done and how we need to continuously align ourselves with national needs. But in order to continuously um, focus the mind and to keep working on translational research, which all of you will agree is not only a lengthy process, but also requires very sustained and committed focus, um, keeping in mind that things shift in the field, competition catches up, new ideas emerge. So it's not easy. And yet, those of you who stay and continue to do that work and help CDRI build a portfolio of products that can eventually be licensed out, to recognize all of this work and to tell you that the institution really supports and applauds this work. That is why we decided also that on National Technology Day, we recognize our innovators. And therefore, those of you who have been involved in patent filing, uh, whether it is in India or abroad, those of you who've been involved in licensing or tech transfer, this is also your very special day. And so we will honor all of you. And the third thing that we started as a tradition is to release the annual report of the Institute. Once again, it's an annual ritual. You might find it tedious, but actually, it's the only way that an institution can narrate its scientific history or provide those who read this in the future or those who read it from outside CDRI a glimpse into what work is going on. In fact, I often refer to annual reports of 20 years ago to see what was going on then, what was the director thinking, what were scientists working on. And they are very insightful documents. So, all of you, all scientists have put efforts into it. And in fact, the annual report is really a collection of all of your scientific narratives, which makes it very special. And of course, there's an editorial team led by Anand, and we will release the annual report today, which is another important ritual in the institutional calendar. So, without further ado, I will now hand it back to Kumar. Thank you very much for being here. I want to thank the organizing committee, Dr. Vivek Bhosle, who's heading the committee, Dr. Kumaravelu, Dr. Vinita Rai, and Dr. Ravi Bhatta. Thank you for your efforts in making this lecture happen. Thank
Thank you very much, ma'am, for this nice intro about the Translational Lecture Series as well as the Technological Day. So I'd like to introduce our speaker today. It's my immense pleasure and honor to introduce our esteemed speaker for today, Professor Ajay Singh, Vice Chancellor of Uttar Pradesh University of Medical Sciences. Professor Ajay Singh is a distinguished pediatric orthopedician, visionary academic leader, and a renowned clinician who has dedicated his life to advanced healthcare, medical education, and patient care in India. With decades of experience in orthopedics and pediatric trauma care, he has transformed the lives of countless children suffering from congenital deformities, fractures, spinal disorders, sports injuries, and other musculoskeletal conditions. His compassionate care and surgical excellence have brought hope, mobility, and smiles on innumerable families as well as children. An alumnus of King George Medical College, a university, Professor Singh established an independent department of pediatric orthopedics. It's the first of its kind in India, making a significant milestone in specialized orthopedic care in India, specifically for the children. He also served with distinction as the executive director of All India Institute of Medical Sciences, Bhopal, where he played a pivotal role in strengthening the medical infrastructure, trauma services, research, and academic excellence. He is a visionary leader. Beyond his clinical achievements, Professor Singh is widely respected as an accomplished researcher, mentor, and administrator. He has authored numerous scientific publications, contributed to medical textbooks, guided young clinicians and researchers, and actively promoted innovation and translation healthcare. His leadership continued to inspire medical fraternity and the next generation of healthcare professionals. Today, we are privileged to have such an eminent academician, surgeon, and humanitarian amongst us. Please join in welcoming Professor Ajay Singh.
ठीक है प्लीज फॉरवर्ड Thank you very much. At the outset, I am really grateful to the organizer for inviting me. And as you have heard that now from a clinician, from a surgeon, I have become an administrator. So for last 4 years, I was not so much actively involved in active research, but still my job changed from doing the research to give ideas to the new researchers so that they can do new things and to try to find out the solution. Uh, what are the limitations? How to recognize the limitation? How to find out the reason, the answers of that, and how, as an administrator, I could have helped them to achieve their goals. That was now is my top my priority. So it's really first of all I must say that I am really very impressed with the campus of this institute, which is very. I mean, I have worked so much years, so many years in the KGMU, and from KGMU when I reached here, so I saw such a nice campus. कोई शोर नहीं, कोई शराबा नहीं, सब शांति के साथ हैं, तो ये बहुत अच्छा लगा मुझे। और मैं डॉक्टर साहब से कह रहा था कि हो सकता है कि 1-2 दिन की छुट्टी मनाने के लिए लखनऊ में यहीं आ जाएँ, आपके यहाँ रहने के लिए। तो थैंक यू वेरी मच फॉर इनवाइटिंग मी। आज मैं जो बोलना चाहूँगा वो एज़ ए क्लिनिशियन, एज़ ए सर्जन मैंने क्या सोचा, अ, कैसे रिसर्च किया मैंने, क्योंकि व्हेन आई वाज़ स्टूडेंट, व्हेन आई वाज़ assistant professor or initial phase of my professional life, research was not considered as one of the key component of your career. As a clinician, research was only meant to publish few of the papers so that you become eligible for your promotion. That's what. So there was, and even NMC is not very strict. NMC is giving 7-8 type of journals where you can go and publish, then you become eligible, and then everything is fine. But even then, I thought to do something innovative. So I faced so many challenges. I cannot enumerate those today because you will not understand कि कैसे हम लोगों ने KGMC में, when there was no culture of research in as a movement, as a comprehensive movement, there was no such environment there. I tried something. So I want to share my journey in the form of a few of my works, which I want to present you. A mind that these all are as a initiation or the pilot studies, and I am sure that from here many of you will appreciate them, and you may take these study further. And I will be very happy if some logical conclusions may be drawn from my initial studies. So these are the uh, 10 translational studies which I'm going to present you, not present you, but share you, so that I will tell my viewpoint, and maybe you will find out some your viewpoint, and at the end, we both will be able to find out some solution, some new concepts out of these. So this is my small, so uh, my introduction, that I'm a I'm a orthopedic surgeon, pediatric orthopedic surgeon, pure surgeon, एंड ऐसा माना जाता है, यदि आप जाएँ केजीएमसी में, तो लोग यही कहेंगे कि यदि आप क्लिनिशियन हैं तो आपको रिसर्चर के लिए एक अलग ब्रांड होता है। इसलिए सर्जन साइंटिस्ट वर्ड मैंने यूज़ किया कि आई एम नॉट ओनली अ सर्जन बट आल्सो बेसिक साइंटिस्ट, नॉट बेसिक साइंटिस्ट, बट आई एम ट्राइंग टू बी द साइंटिस्ट। अ, जो साइंटिस्ट होता है या सर्जन होता है, दोनों के पास ही बहुत ही लॉजिकल एनालिसिस करने की कैपेसिटी होती है, और रिसर्चर के पास भी ये जो कैपेसिटी होती है ये कॉमन है। इसलिए मुझे ऐसा लगता है एक क्लिनिशियन और एक साइंटिस्ट जो होता है वो दोनों आर इक्वल, एंड तो दिस इज माय स्मॉल थिंग्स, दैट माय विजन एंड फिलॉसफी वाज दैट many things we study, and these studies were limited to only lab, and there are many diseases which we examine in our OPDs, but there was no correlation. Nowadays there is a changing environment, but initially when we were working there was no correlation between the labs and uh, the OPDs. So that was the concept of translation medicine. So my aim was to bridge the gap, this gap between the lab and the clinical material, empower the orthopedic surgeon to be the clinical scientist. This is very basic concept of mine, and I always push my students to do good quality of रिसर्च। मैं हमेशा अपने स्टूडेंट से कहता हूँ, आपको आपकी रिसर्च का मतलब ये नहीं है कि आपको कोई नोबेल प्राइज़ मिल जाए, या आप जीनोमिक्स पे जाएँ या मॉलिक्यूलर स्टडीज़ करें। आप क्लिनिकल स्टडी भी कर रहे हैं और उसको उससे कोई आप अ, कोई कंक्लूज़न निकाल रहे हैं, एंड यू आर प्रोड्यूसिंग ए हाइपोथेसिस टू द रिसर्चर or the scientist, then that is your job is done. Then I'm very much interested in finding out the biomarkers. The biomarkers, not only the diagnostic biomarkers, but prognostic biomarkers, I'm very much interested. So that during the early phase of the treatment, I can give or predict what would be the outcome of this disease, or how we can find out uh, the changes in a very early stage. And of course, my job is to give the support to my next generation clinician as well as the scientist. So everybody knows what is translation medicine. It is something which convert the lab findings, lab knowledge to the clinical outcomes, so that we can change our SOPs, our clinical practices. We can change through the outcome of these, and we can give the feedback to the scientists who are working in the laboratory, that how much more work they have to do, in which direction they have to go further, so that they can ultimately, our aim is to give maximum benefit to our poor patients. That is the only criteria for me for any success. So first study which I will tell you is the heavy metal burden and the burden of metallothionein 2A in the primary osteogenic sarcoma. I don't know how many, but osteogenic sarcoma is a malignant bone tumor which develops in early 20s, mean young generation, young population is affected by this osteogenic sarcoma, and the prognosis of osteogenic sarcoma is very poor. Means even uh, death can happen if it is not diagnosed and treated well. In otherwise, the chances initially when I was a student, the amputation of the limb was the only treatment present. But now we are having chemotherapies as well as uh, new type of surgeries in which we can save the limb if it is diagnosed early. So I chose for this metallothionesin because this is a cytotoxic agent which is related with the metabolism of the heavy metal, and heavy metals are nowadays very much available in whole of the atmosphere, and without paying some anything we are inhaling those heavy metals, and these heavy metals are affecting our the health of our bones, and if the heavy metals are more, then even the materials which are suggest which are supposed to do the uh, metabolism of these heavy metal will increase, and if we can find out that these are the concentration which is higher than the average, then the chances of the success of the medicines which you are giving chemotherapy which you are giving for the chemotherapy will be lesser. So at the initiation of the treatment you will be able to find out this is a risk factor patient in which there are high chances that the primary line of treatment will fail, and we have to think of a higher line of treatment. So with this idea, I have chosen this heavy metal and metallothionein, and we have studies between its concentration between the patient affected with bone tumor and the normal population. I have done it, and it was my study. I mean, it was based on my hypothesis that if it is elevated, then the chances of the resistance against the chemotherapy, which will be very high, and the prognosis will become poor, which is already very poor. So I was supposed to give something to the researchers as well as to the policy makers that this is something which we have to add into our lab investigations if we are treating osteogenic sarcoma. So it's a cohort study which I conducted. Every study I have conducted at KGMU. So that is my setting, and I have done only prospective study with short-term outcomes, but it needs a long-term outcome study also. I think with the help of you people, maybe we clinician be able to do it for a longer period so that we can find out the ultimate changes in our uh, clinical outcome protocol. So it's a I have already told that I have compared the patient with the normal population, and we correlated it with the grading of the tumor, which was done before the starting of the treatment, and then after the treatment, how the grading was changed from initial grading, and what was the load of the heavy metals, and these in the patient's blood, which was having a correlation with the prognosis of the patient. So this was the biomarker we have measured is the lead, cadmium, and Western blotting assay we have done for the MT2A expression. Mind, all this labs work is not done by me. It's done by my colleagues who were there uh, in the KGMU. So my aim was only to give the inputs to them, and as per our discussion, they were doing the work in their labs. And then we compared the radiological, the concentration of the heavy metal with the severity of the disease. How's the severity of the disease? By the checking the X-rays as well as checking the histopathological grading of the tumor. And what was the outcome of the chemotherapy in both type of groups of the patient? That was my study. So the results, or which are the main highlight of my study, was that uh, it was a high concentration of heavy metals and MT2A in the patients of osteogenic sarcoma. And in those patients in which it was higher, the response of the chemotherapy was poor, because the conversion of grading from severe to milder was not present in such patients. So we concluded that the heavy metals are one which is affecting the prognosis of this tumor. And when the prognosis of this tumor is being affected, any disease which is affecting the bone biology will be affected by, means osteoporosis suppose is one of the many very common disease. So osteoporosis would be affected by the presence of heavy metals in your blood. So that was my that was our conclusion. And we have seen that there is a significant higher concentration of MTUA upregulation was there, which was higher in the uh, affected tissue over the controls. Controls we got from the operations, bone pieces from the normally fracture patients or the arthritis patient, in which we used to throw the bones, we used to collect it, and after ethical clearance, we did this study. The radiotherapy resistance, because osteogenic sarcoma is treated by chemotherapy as well as the radiotherapy. So not only the chemotherapy is not effective, even the radiotherapy was lesser effective in such patients. So majority of heavy metals was in patients was the lead and cadmium. These were the lead is very common. Even you inhale the smoke of the uh, traffic. If you are passing through a traffic and you are inhaling, the majority of the heavy metal is the lead which you are inhaling, and that is competing with the calcium, and your bone biology is become poor. So we have seen that the prognosis differ from milder grading to higher grading, which is in correlation with the presence of heavy metal. And when the heavy metal was present, then this can be used, the MT2A can be used as a biomarker, prognostic biomarker, which can suggest that the prognosis is poor. So we tried to make it, though it was the initial finding, and could not be taken up further, because it was a potential biomarker which we have tried, but we have not used anywhere else in any other institute. So that was a limitation of our study, but this was something which was very relevant as far as the treatment protocol is concerned. and we concluded that 2A, MT2A is a marker which is present not only in blood but also in the tumor tissue, and which is very much a prognostic biomarker and can predict the failure of the treatment or switching over to higher type of chemotherapy or the radiotherapy at a much early stage, so that we can prevent the loss of the limb and the loss of the life in such patients. My other study was uh, CCN is based on the CCN 1, 2, 3 in a disease which is known as Perthes disease. This disease is occurs a congenital, not congenital, but developmental disease in children. Children affected from 4 years to 6 years, maybe 8 years, are developing hip arthritis. A child of 6-year old developing uh, hip arthritis, which is non-curable, no definite treatment, no definite cause is known till date, and there is a development of arthritis which is going to affect the adulthood, and the only treatment is either you diagnose it in early stage and start some treatment, otherwise you will lose the hip which is healthy and you have to replace. So at the age of 6 months, 6 year or 10 years, it is not advisable as an orthopedic surgeon to replace the hip joint. So that was the significance why we choose this Perthes disease. And you must be knowing what is CCN, and we choose the CCN 1, 2, 3, so that in the blood, the presence of the CCN 1, 2, 3, whether it is any way correlated with the severity of the and the natural history of the Perthes disease or not, or it whether it can affect the overall outcome of the patients or not. So that was the my hypothesis, that it is correlated with the uh, in comparison to healthy people, it is correlated with the severity of the disease, and non-invasively we can find out without exposing multiple times to the patient to the X-rays and the MRIs. We can find out by getting 2 ml of the venous blood. We can find out this biomarker and can predict it. So this was a study in which uh, we have studied 62 children, and it is bilateral. So hip we have examined 62 into 2. Uh, so many hips we have examined in this, and we found that we have different assessment tools which have I have already mentioned to assess the severity, which was radiological severity as well as the clinical severity. Then we took this blood from the 2 ml blood from the patient, and we our target genes were uh, CCN 1, 2, 3, and how this is expressing and what was the concentration, what was the significance, so that the prognosis can be predicted. So this is something which is showing that how the CCN gene expression was different from severity. The heading A is a radiological grade which is milder, and heading C is the most severe type of the arthritis. So you can yourself see that the expression was much higher with the severity. Means if more expression is there, you can predict that in due course of time, the chances of converting of milder stage uh, to the severe stage is much higher. So this was a result which is apparent in this slide, and we have find out that CCN2 was having the strongest correlation with the severity. So out of three, we could find out though the correlation was present in all three, but the highest was CCN2. So if CCN2 we can predict, we can take out during the early staging of these patients, probably we will be able to start the treatment, whether it's a conservative treatment or the surgical treatment, in a very early stage, so that we can preserve the hip of the child, so that the adulthood complication can be avoided. So the conclusion of this study was that peripheral CCN 1 to 3, all three, out of three, the two was the most significant. So was something without hampering the local tissue, means without taking out the bone pieces from the local tissue. By getting 2 ml blood, you can find out what is the concentration of this gene, and this gene can become a biomarker for a future for future prognosis. But again, the limitation was that it was in only very limited patient which came to us in our OPD, and so we need a multi-centric study so that we can really see whether this gene's expression is really correlated or not. The third one is the infection. What we have done to find out uh, that delayed fracture related, FRI means fracture related infection. Two type of infections are there. One infection occurs as soon as you get a injury, and you get a wound and the bones become infected. That is acute. The other is delayed. Suppose you have done some surgery, you have put in some implant, you have fixed the fracture, and after 2, 3, 4 weeks, patient develops the infection. That comes in the delayed fracture related infection. In India, majority of places, that their treatment and the care of acute infection is available. We don't have any method to predict whether this patient will develop FRI or not. So this was a biomarker which we have tried to correlate with the occurrence of delayed FRI in our study. So I have already told you why it was so important. So we have adopted three biomarkers: CD64, other is CD66B, and one very innovative biomarker we have chosen is thyrodoxine. So this was a a protein which is oxidative stress protein, which is elevated in the infection and sepsis. So we predicted that if there is no clinical infection is there, even then, if in blood it is increased before the clinical signs of the infection, then we can predict that this patient in due course of time will develop infection, and we can take the preventive, the measures which can prevent the FRI. So this was we have enrolled 637 patients. Mind this was not infected bones. It was healthy bones which got fractured, and we fixed them with some steel implant, and after that whether they are developing infection or not, that was this. So we took blood, 2 ml blood preoperatively, that at day 3, 7, and 10 after fixation. And we have many conventional biomarkers, polymorphs, the ESR and CRP, which is a standard protocol we predict. And our three biomarkers which we have mentioned here. and we tried to do the analysis by ROC, and the area under the curve was examined to see the significance of these biomarkers as far as the occurrence of the infection is concerned. So this was we have chosen the novel versus conventional biomarkers as far as ROC and the area under curved is concerned, and we compared it, and we compared and we found that the CD64 at day 10 had a sensitivity 91% with with AUC 0.93, that is the highest one. 0.93 was the AUC of CD64, but CD64 NPV was 99%, which was a gold standard, and out of this NPV we have gone for CD64, and other biomarker, that is thyrodoxine, is again not as effective as CD64, but it was also having a very good correlation with the infection occurrence in a delayed form in these patients, and it was become a significant level at day 7. So within 3 to 7 days, we have multiple biomarkers which can predict the probable cases of infection development after the close successful surgery of the fractures. So this was a very, for me, that was a very significant thing for the clinicians. If we join all the three biomarkers, so within 10 days, I think 99% you can predict the patient in which the infection will occur. And if we are having this knowledge, then I'm sure everybody knows that infected bone is very difficult to get rid of the infection from the bone. So again, it is a limited study. It needs higher and wider examination by various scientists so that we could find out its real uh, uh, impact on the clinician on the clinical practice. And but it is something which we have started doing, and it is of tremendous, because we are losing so many beds, so many days of admission, so much of antibiotics. We are wasting everything on these patients. If we can predict it, we can take preventive method much earlier than actual development of the infection. Next is clubfoot. I don't know how many people knows this clubfoot. It's a congenital foot deformity of the children, and we tried to find out whether any gene expression can be predicted, because the treatment of this clubfoot varies from plastering to surgery. And what is the normal practice is we apply the plaster first for 3-4 months. After that, if it is not successful, then we go for operation. And you know that the operation doing after a significant age, then the prognosis of the operation become lesser. So if we can predict in early stage that this patient, the chances of failure of uh, conservative treatment, that is the plastering, if it is there, we can give the prognosis, true prognosis to the parents, so that they will be mentally prepared that there is high likelihood of failure of the plaster, and if you are switching over, they will not make any noise of this. So this was something in which we not only did the blood, we took blood from the children, but also from the mother, because all these babies were less than 3 months or lesser age. So we took the concentration of these genes in the mother as well as in the child, and we examined the both. And why we have chosen this gene, because it is a critical component of the articular cartilage development and the joint architecture. So we have chosen this particular gene for this purpose, and we have examined 125 children, and it was a mother-child diet, and 125 mothers of the, not father but mother. Why father we have not taken? We have done some in which mother, father, and child, all three were taken, but most of the uh, times father is not available most of the time, so we dropped that for practical purposes. Otherwise, ideally should be father, mother, and it should be a triad. So uh, we have seen that the Pirani scoring is the clinical severity of the disease. We assess the clinically what is more severe, and we try to correlate the gene expression with the clinical grading of the disease, and we try to correlate it whether there is any correlation or not. So it is, we have seen that it was a positive correlation between the severity and the expression both in mother as well as in child. So what we propose, that why not prenatally we should go for getting these genes in in high risk patients in which there is a positive history of such deformed foot in the family. So if there is family, then these are high risk, and why we are not going to examine these in the prenatal genetic counseling, so that the early intention can be getting, and we will be able to find out the etiology, the cause and pathogenesis of the disease, which is still unknown. The, the next again comes, in which we have uh, already done this biomarker in a more number of patients for a longer period of time. We have examined CD64 and 66B versus the conventional in the patient of FRI. And we have seen that when the 66B, which was we were thinking of that there will be a significant change, we found that there was no significant correlation of this biomarker with the infection. Rather, CD64 at day 10 was greatly significantly uh, uh, correlated with the occurrence of FRI. Next was again of osteogenic sarcoma. In osteogenic sarcoma, this time we are not concentrating on heavy metals, but we were concentrating on CCN. CCN is one protein which is related with the fibrosis and the angiogenesis. And you can understand the component of any bone formation, any tumor formation, the angiogenesis and the fibroblastic activities are very important component as far as this the prognosis of the bone is concerned. So again, it was a prospective case control study, 35 primary osteogenic sarcoma patient versus 10 uh, healthy bones we have examined. And we examined CCN3 protein, and the key results were that the CCN3 significantly upregulated in osteogenic sarcoma tissues versus control, and it was correlated with the histopathological, which was the gold standard of examining the severity of and determining the treatment of this osteogenic sarcoma. The CCN was correlated with that. So it was a very significant, that I'm not saying that this will replace the histopathological examination. No, that is the gold standard. But still, by getting this, you will be able to find out those patients in which there is likelihood of failure of your conventional treatment. So what we predicted that we must combine the CCN3 with the blood investigation or lab investigation in all our patient of this sarcoma patient, so that we can do the future planning of the treatment of this patient. Next comes the fracture healing. Fracture healing again is a very, very important and very notorious. Some bones are very notorious for delayed healing or non-healing, and there is no method today available in which at the time of fracture you can predict that whether this bone is going to heal or going into a delayed union or in non-union. You cannot, you don't have any treatment. Even after the treatment, after the surgery or the conservative treatment, you cannot predict and you cannot tell the prognosis. So this was the thing. And what we did that we examined uh, 121 121 patients, and we followed till the 24 hours. And RUS scoring is the scoring, radiological scoring, which gives us the idea of the nature of healing, bone healing. So it's a radiological parameter which gives us that whether bone are healing in proper manner or in a delayed manner. This will help us. We found that out of 121 in 19, there was a impaired healing as far as RUS score was concerned, means radiological. But RUS score that gives us the impression after few weeks, not immediately. So we have collected blood, and it was started from day 4, 7, 10, 15, 20, 28. Then we correlated for a long period till the bone healing is there, and we tried to find out whether there is any significance of any osteocalcin and osteopontin with the bone healing or delayed union. And you can see that microRNA correlation with the RUS score at most of the time was significant as far as these uh, osteocalcin and osteopontin is concerned. So we concluded, not concluded, but we predicted that these two can be used as potential biomarker for early prediction of those patients which can develop delayed healing, and we can take preventive method in the form of early intervention for these fractures with the consultation and giving the prognosis to the parents. This will decrease the overall stress, and uh, the fracture disease pattern of the patient will be much subsidized by studying this biomarker uh, in the early stage. Next was we studied a biomarker in spinal cord injury, which is PNFH is a biomarker which is concerned with the neural healing, and we predicted that can this measurement of this biomarker in blood can predict early prediction of the fate of spinal cord injury, because spinal cord injury results are very slow. It varies from 3 months to 6 months, maybe sometime 12 months. It varies from. So can we predict it early that what is the concept, what is the change would occur in spinal cord injury or not? So there were Asia score is a clinical score which give us whether it's a complete injury or it's an incomplete injury. That is I have mentioned here. And this biomarker is a structural axonal protein And when axon are damaged in spinal cord injury, then this is released in the bloodstream, and by concentration, by measuring its concentration, we can predict the severity of the disease, of the injury of the of this spinal cord. So it was a observational study in which we have examined 40 such patients, and we have measured the PNH, PNFH at the time of admission, and then serial follow-ups were taken up. And these are the patients, and we have measured that the mean PNH, PNFH in cases in spinal cord injury was 6.4 in comparison to the normal, that is 0.45 was in normal. So it is also there in normal. In normal, 0 is not there, and there is a correlation, positive correlation between PNFH as a blood-based severity marker of acute spinal cord injury with the with the Asia score, that is the clinical. So we can predict, after measuring this biomarker, early prediction of the fate of recovery of spinal cord injury, which is a major matter of morbidity in majority of the patients. Again, heavy metals. I have done many studies in the heavy metals in Perthes disease, which Perthes I have already told you, and we have seen that Perthes disease, 73% patients of Perthes disease are having abnormal high concentration of lead in their group, and it is correlated with the severity of the disease. So we found that this lead concentration is positively correlated with the clinical radiology severity of the disease, and it is more of diagnostic and observational study, because whatever heavy metal is present in your bone, there are very less chances that you can remove those heavy metals from. But only thing, if it is there, then you have to think that the chances of becoming more severe are higher, and you have to take preventive measures to change your treatment or to give the prognosis to the parent. So it's a heavy metal. I'm again and again saying that it's an environmental problem. Everybody is, all of us are inhaling lead फ्रॉम आवर पेड्स, जो हम लोगों की दीवारों पे हम लोग पेंट करते हैं, जो हमारे यहाँ पे इन्वर्टर्स की बैटरीज रखी हुई हैं, जो हमारे व्हीकल से जो भी स्मोक निकल रहा है, इवन गांव में जो लोग जो कुकिंग करते हैं लेडीज, उनमें से उनका भी जो स्मोक है, उसमें लेड है। कॉस्मेटिक जो लेडीज यूज करती हैं, आजकल जेंट्स भी यूज करते हैं, उनमें भी लेड की कंसंट्रेशन, यदि बहुत अच्छे स्टैंडर्ड कंपनीज के आपने ले लिया, तो उसमें भी लेड बहुत ज़्यादा होता है, और आप बिना जाने हुए यू आर इनहेलिंग, और you are taking into these lead in your bones, and bone become osteoporotic. Then we start working on osteoporosis, but start working on heavy metals, then you will be having a more healthy bone than real bone. So this was something which is very much there, and my my proposal is to study the heavy metal with the genes modification, whether it is affecting the genomics or not. I predict that these heavy metals not only affect the bone biology but also genomics also. And if it is affecting the genomics, then you can understand, from mother to child to third generation, everybody will be affected by heavy metals. This is again one more marker for tibia fracture healing. CYR61 is a angiogenetic biomarker, because it is known that if the angiogenesis is good, means the blood formation is good, the healing will be better. If it is not there, so we try to correlate it, and from day 4, 7, 10, 15, 20, we have taken the blood at these intervals and tried to correlate the expression of CYR and the rest scoring, and we have found out that it was significantly high even at day 4. So you can understand the significance of this biomarker, which is present higher at day 4. और आपने डे 4 पे यदि आपने समझ लिया कि इस पेशेंट में ये प्रॉब्लम आ सकती है, तो आपके और पेशेंट की दोनों के लिए क्लिनिकल बहुत ज़्यादा सिग्निफिकेंस इसकी हो जाएगी। एंड so I feel that this biomarker should be more studied because you people are working on bone healing. So I think these are the marker which we have started working, and naturally we should move forward. So these are the collective biomarker landscape, and I am very fond of working on prognostic biomarkers. Diagnostic are many there, but prognostic biomarkers are very few people are working on prognosis. So I request you people work on the prognostic biomarkers so then we can predict the things in a much early stage. So this is a small thing, a small slide, how to do is research journey. I think I'm not supposed to speak on this because these you people are will tell much better way. But I feel that affordable diagnostics in the form of biomarkers and the other diagnostics are very, very important. Today is the era of precision medicine, and precision medicine is very significant, and we must practice as a clinician the precision medicine, and how this precision medicine can be effective by help of you people, that you will find out the new biomarkers for us so that we can predict in which patient at what time we can do the intervention, and that intervention would not be uniform for everybody, but it will be specific or precise to that particular disease in that particular patient. That is precision medicine, so that we can do the timely intervention and can get rid of many complications and morbidity of the patient. So this is my last slide, that translation medicine is not a luxury for me. It's a very important thing, but unfortunately, there is very less correlation between the clinician and the scientist. So there is a concept of uh, yeah, or physician scientist. There is a concept, but till we are developing physician scientists, we must have a correlation, close correlation, active, healthy correlation between the scientist and the clinician. Every clinical observation has the potential to become a life saving discovery. तो थोड़ी सी छोटा ऑब्जर्वेशन भी आपके यहाँ पे यदि आपको कुछ दिखता है एज ए क्लिनिशियन या एज ए रिसर्च एज ए साइंटिस्ट, उसको हम लोगों को फर्दर स्टडी करना चाहिए, क्योंकि दैट बिकम ए ट्रिगर पॉइंट फॉर योर फ्यूचर. द जर्नी फ्रॉम बेंच टू बेडसाइड डिमांड्स पेशेंस, कोलैबोरेशन एंड साइंटिस्ट. मैं आपको बता रहा हूँ एज ए क्लिनिशियन, हम लोगों ने बहुत झेला कि ये तो लैब में घुसे रहते हैं, ये सब यही सब बातें करते रहते हैं. इनको लगता है इलाज-विलाज करने में ज़्यादा इंटरेस्ट नहीं है, ना ही ये अच्छे डॉक्टर हैं, ना ही अच्छे सर्जन हैं. ये सब ये लैब वाला काम करते हैं. ऐसा ऐसा एक टेंडेंसी होती है. ऐसा नहीं है. मुझे ऐसा लगता है कि जो अच्छा क्लिनिशियन होगा, जो अच्छा रिसर्चर होगा, वो क्लोज़ ऑब्जर्वर होगा और वो छोटी-छोटी बातों को देख के उसको एनालाइज़ करने की कोशिश करेगा, वही रिसर्च होती है. सर्जन कैन बिकम एंड मस्ट लीड ट्रांसलेशन साइंटिस्ट. अ, सर्जन्स के लिए तो बहुत बड़ी बात कही जाती है कि सर्जन का काम सिर्फ़ ओटी के अंदर होता है, बट आई एम अगेंस्ट दैट. द बायोमार्कर डिस्कवर्ड हियर, there are many biomarkers I have done. I have more studies, but I chose only 10. And the next great translation research paper may become someone in this room today. All these are students are sitting there. So the science begin with a question. जीवन में याद रखिए कि क्वेश्चन जरूर होना चाहिए. मैं जब मैं स्टूडेंट था, तो एक हमारे हमारे सर्जन होते थे. वो एक ऐसी डायरी रखते थे और मैं आज तक रखता हूँ। आज मैं ऑलमोस्ट मतलब इस पोस्ट पे पहुँच गया हूँ। इसको कहते थे जिज्ञासा डायरी। जिज्ञासा जो मन में आए, उस जिज्ञासा को डायरी में नोट कर लीजिए और उसका आंसर ढूँढने की कोशिश करिए। यदि आप जिज्ञासाओं का आंसर ढूँढना कोशिश नहीं लिखेंगे तो आप भूल जाएँगे, लेकिन आप लिख लेंगे तो आंसर करेंगे। तो छोटे-छोटे क्वेश्चन जो आपके आते हैं और छोटे-छोटे क्वेश्चन जो मरीज़ आपसे पूछते हैं, उनको हम लोगों को फर्दर स्टडी करना चाहिए और यदि हम ऐसा करेंगे तो ज़रूर हम एक दिन वी विल चेंज द वर्ल्ड। So with this, thank you very much.
Thank you very much, sir. I think I'm audible. Yeah. So thank you very much, sir, for getting smile on 5,000 more patients. I give him one round of applause for him. Truly inspirational talk and translational work which you have done, and you have changed the treatment regimen of all the people. And one more idea what he gave is to write down all your ideas on a Jigasa diary. Please note it down and try to make your change your lives also. So thank you very much, sir.
Thank
Yes, please, please. So may I request Dr. Radha Rangarajan and Dr. Vivek Bosle on stage, please. So I think if you have any questions, maybe one or two questions, Dr. Professor will be able to answer it, please. One or two questions.
It's just a quick query, sir. You showed number of markers. I was just wondering, postmenopausal age bones to become very weak. So you ever tried just like checking these markers, how they are changing maybe after the menopause?
I have not studied because I am more interested in many people are working on postmenopausal osteoporosis, which we were discussing before coming to this
Right.
place. I was working more in the male osteoporosis. I am concerned in osteoporosis in young female, which is who are not postmenopausal. Why they are developing osteoporosis? Because we have the answer that why uh, postmenopausal osteoporosis is there. We don't have the answer why we are getting osteoporosis in young patients. That too in the males. Why we are developing? So this is the area which needs more attention now
Mhm.
for me rather than in that. So I have not studied yet because I have shifted my interest to the male osteoporosis and the premenopausal.
Yeah, I was just curious, like, what's the scenario of these
No,
markers?
I have not.
Thank you for the lecture, sir. So my question is regarding the study design. You have chosen prospective study,
Sorry,
study design.
prospective.
Yes, sir.
Yeah,
But why don't you goes for the ICT, as ICT is considered as the gold standard for the
Sir,
clinician?
you have seen RCT. I have not used the word of RCT, but it is something because RCT only you will do when you are prospectively you are studying the population with a definitive role. We are getting not we are getting some biomarker for getting the initial knowledge whether it is of any use or not. After getting this pilot study, only then you need a large number of population. Only then RCT would be effective. But even in this pilot study, I have done a control group as well as a disease group. So there were two groups which were compared with each other. Of course, it was not randomized because the in in one group in one study it was 62 patient, in other 121. It is such a small number. It's a pilot. For me, it's a pilot study giving us the uh, 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 an idea how to improve, when to improve, and when to proceed to the RCT for the larger population.
Thanks a lot.
One last question, please.
Yeah, I saw your biomarker studies of Perthes disease. in which you've shown CCN isoforms as marker and especially CCN1 on the basis of mRNA expression. What was the status of the proteins in these studies?
Madam, I can give you the uh, my opinion about the expression and what was the expression. But rest, very minute thing I cannot tell because that was done by my doctors who were there was at lab. So I don't have the idea. Presently, I don't have idea, but I will give you the answer after discussing with this. Okay.
So, man, thank you so very much, sir, for your excellent talk. May I request Dr. Rangarajan to felicitate our speaker? Thank you very much, sir. Now I request Dr. Naseem to take over and continue the program, please.
Good afternoon, everyone. It's the most awaited moment for all our scientists who have been working tirelessly to come up with technology and patents. And before going to the distribution of the to the investigators, the patentees, and the technology team, I would like to put on record the special thanks to our headquarters CSIR, uh, the the ORDIP, IPU, Technology Management Directorate, the Institutional IP Committee, BD Committee members, and of course, our the most important pillar of the Institute, the Director CDRI, who is the chairperson of the IP and BD Committee, who has been tirelessly guiding and mentoring the entire Institute, and in particular the IP and BD Committee, for taking these lab discoveries to the market and to the next TRL levels. Thank you, ma'am. And thank you all. And the last year was really a fruitful year for all of us. We filed total 6 patents, and out of which 4 Indian patents have been filed and 6 foreign patents were filed. But for these 6 patents, we already actually awarded them last year during the last technology day function. But nevertheless, we'll share their names, the patents, so that you know that how the effort goes on and on to take the discoveries to the next level, to the next countries, to different territories. To begin the awards, the number of patent filed in India, 4. The first patent, I would request the title of the patent is for the synthesis of alectinib, and I would request the inventors are Soumya Singh, Arun Yadav, Chandrabhushan Tripathi. May I request the patent? Are you fine? Quickly, quickly, we have a long list. No issue. We can quickly have the group photo. Then we have a second patent. It's a joint patent from IICT for antibacterial activity. May I request Dr. Siddharth Chopra, Akash, Shivani, Rahul, Deepanchi, and Dr. Haridas from IICT. The third patent is for peptidomimetics process for preparation and applications thereof. It is again a joint patent between IICT and CDRI. Siddharth is again on the joint patent list with Debrata Mehti from IICT and SK Rajibul, Subhadeep, Dipanshi, Rahul, Swechha. This also shows a good sign of collaboration, what sir was mentioning, that research for a translation, you need to have a collaboration, and the story tells you that it actually results a joint patent and followed by translation. The next patent to be awarded is on triple negative breast cancer. The inventors are Debendu Banerjee, Khushbu, Ananya, Vijay Kumar, and Sumaira. With this, we complete the list of the Indian patent filed this year, which whom we are awarding this year. But nevertheless, as I mentioned earlier, that last year we felicitated the patent which I am now referring in. These are the PCT patent application. But I'll really read out the names for the patent called thiourea based derivatives, and it is actually a patent among three organizations between IIT Kanpur, Helmholtz Institute, Germany, and then CDRI. The patentees are Dr. Sandeep Verma, Dr. Siddharth, Alexander, and Marta. I think they need your clapping at least so that they have been working. It's a PCT patent application. Then the new patent is which was filed in Canada, US, and Europe. Novel substituted aminopyridines receptor modulators and uses thereof. The inventors are Dr. Atul Goyal, Dr. P.N. Yadav, Parimal Mishra, Sakshi Mishra, Jagriti Singh, Sazia Parveen, Ankita Mishra, Anu Yadav, Wahajuddin, Swati Chaturvedi, and it's a patent file in Canada, US, and Europe. That's a great story to reveal that CDRI, Dr. Drills Institute, again, it's a story of collaboration which is moving on for translation. And the other patent is the PCT application, which was filed on N-functionalized indole compound as antimicrobial agents, process thereof. The inventors are Ravindra Kumar, Siddharth Chopra, Arun Kumar Sinha, Abdul Akhir Dipanshi, Rahul, Sumit Kumar, Subrata Rao, and Santosh Kumar. I think it's the inventors on the patent. Last but not the least, the PCT application up for amino acid based poly PARP inhibitors process for preparation and thereof. Dr. Gautam Panda, Soumya, Indranil, Souvik, Kasim Ali, Sachin, Supriya, Sanjeev, Dr. Gayan, Amir, Smriti, Deepak. These are the inventors, and they are moving on to the next TRL levels, and the development is in progress. These were the patentees, and hopefully we are moving to the new territories. The research is ongoing. With this, now we move on to the most awaited, and which takes the next level from translation to commercialization stage. And of course, the story is that we were able to license the technology of chebulonic acid energy fraction for the management of benign prostatic hyperplasia and its process thereof, which has been licensed to the country's one of the biggest company of the country, Himalaya Wellness Company, Bangalore. And I really congratulate the team and would request the team members to. The list is long. I would request to read out your name. The photos were there. Anyways, the inventors, the technology development team. I'll read out the name, but you can really walk into the stage. Dr. Narendra, Monica, Sanjeev, Ravi, Dr. S.K. Rath, Madhav, Prabhat, Manish, Shubha, Sachin, Kumar, Kashif, Baisakhi, Siddharth, D.K. Mishra, Vinita. Of course, I will also join Preeti, S.C. Tiwari, A.K. Pandey, Ram Lakhan, Tripti, Shiv Kumar, Ankit Agarwal, Deependra Mishra, Bilal, Sarvesh, Arpan, Sandeep, Sonam, Pankaj, Priyanka Rawat. I think you can bring out the certificates. Everybody can hold the certificates quickly. Mohsin Ali, Sheba, Smriti, Pankaj Shukla, Ramesh Chandra, Sachi, Deepmala, Vivek Bhosle, Shripati Kulkarni, Suresh Kumar Batina, Anand Kulkarni, Anil Kumar Meena, Ranveer Singh, Akhilesh Kumar, Sudhakar Yadav, Shraddha Jain, Neelima Jayaprakash Dwivedi, Farah Khan, and Navodayam. I mean, the list is long, but I should say your clapping should go on as it is the most awaited moment, and actually, it is required for everyone for translating this lab discovery to take to the next level. And I am keeping my fingers crossed that once I come back to you next year, we'll have the product launch from the same stage. So need your blessings so that we keep moving with the development. And thank you all the contributors for this important technology and bringing this novel solution for the global market. Thank you so much. Thank you, everyone. चलो मैं बाद में ले लूँ ठीक थैंक यू हाँ after this now we move on to the release of annual report. It's a document which actually tells the story to the outer world, which actually goes on throughout the year. Lot of things that happened during the year, and just to tell you that it was actually the 75th year of the institute, which we really completed very successfully, and the rest is history. Before taking, I mean, not taking much of your time, I would request the dignitaries to release the annual report. Anand, the editorial member team members, if you're here, please join us on the stage. और लोग हैं this report becomes more special as it is the 75th year of the institute, and which is going, it's a landmark a document. Yeah, oh, I was not knowing that actually that cover page was having 75. So it's really something very important for all of us. And thank you, the editorial team. And thank you, Director Ma'am, for all your guidance for bringing out this the entire document. It will be a historical and landmark document for all times to come in the history of CDRI. And I think we had a group photo. Okay, thank you. Thank you. With this, now I would request Dr. Vivek Bhosle to propose the vote of thanks. Dr. Vivek.
So it is my immense pleasure to propose a vote of thanks. Actually, we are very thankful to Dr. Ajay Singh, who is a Vice Chancellor of UPMS, who has taken the time from his busy schedule and given us an excellent translation lecture. It's a true translation lecture that he has studied the disease from various angles, from gene expression, from biomarkers. Particularly, we are taking home the message that prognostic biomarkers are more useful, and we will more concentrate on the prognostic markers. So I will also thankful to Dr. Radharangan for arranging this lecture series of translation series, and her wish is that more people now should work on the human samples so that they will get inspiration from these immense lecturers, and then we can have a more ethics committee meetings. We will have a more translational papers from the institute. I also thankful to the organizing committee, Dr. Kumar Vilu, Dr. Ravi Bhatta, and Dr. Vinita Rai for organizing this lecture. Then I also thankful for the bone biology group, particularly coordinators Dr. Atul Goel, Dr. Divya Singh, Dr. Ritu Trivedi for the excellent session for the discussion with the our eminent speaker. Then also thankful for the business development team, Head of Department, Dr. Naseem Siddiqui, then Suresh, who is taking care of patents, Nilima, Shraddha, Jay Prakash, for organizing this National Technology Day. I also thankful for the PME department, particularly Dr. Head of Department, Dr. Anand Pilkarni, Shruti, Farah, Ashok, etc., for the release of the annual report, preparing the annual report. I also thankful for the auditorium team, Mr. Sumit and his colleagues. Then most important that photography, Dr. Ravi Londe and Kazim has made a significant contribution for photography as well as making the certificates on time. They have taken lots of efforts to printing and etc. Then Hizas and Sanjeev Yadav has done an excellent job for organizing this event, that they called other institute people here to take inspiration from the eminent speakers. I also thankful for the ERA Pharmacy College and their students who have come here and attended this lecture. I think they can take home the message and they can start the research at their own institute. So uh, uh, we are thankful for all your busy part of these duties, and we will immensely now take up forward our science and technology together in the next year also. So I am concluding my thanks. Now we will do the national anthem because we have celebrated the National Technology Day. So everybody should stand up and we will have a national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे